Welcome. Thank you for joining us for this webinar examining how the COVID-19 pandemic has impacted our efforts to end the HIV epidemic in the United States. I'm Jeffrey Crawley, the Director of the Infectious Diseases Initiative at the O'Neill Institute for National and Global Health Law at Georgetown Law. This webinar is being conducted as part of our partnership with Gilead Sciences. When the COVID-19 pandemic emerged, it required all parts of our health system and really society to respond to this serious crisis. But not everyone's role was equal. I think many people can acknowledge that the HIV community, both our clinical providers and community members, and our related practitioners working to address hepatitis and sexually transmitted infections, were disproportionately responsible for responding to COVID-19. The nation needed us to step up because we have the experience and expertise to respond to this type of emerging crisis. But we also have to continue our work to address a very serious HIV epidemic. We need to remain focused and really rededicate ourselves to working to end the HIV epidemic and reducing the large inequities that fuel HIV in so many communities across the country. Today, we're going to hear about two new reports that document how COVID-19 impacted efforts to fight HIV. To some extent, we already knew this, but these reports offer new documentation and evidence of this impact and also give us new information to both learn lessons from COVID-19 and allow us to spotlight areas that need the most focused attention moving forward. First, we'll hear from Susan Silseth, who is a consulting actuary at Milliman that looked at the impact of COVID-19 on HIV testing, diagnosis, and treatment in the United States. Then we'll hear from Tristan Maras, head of research and reports at GLAAD. They've recently published a study, Invisible People, a retrospective report on the impacts of COVID and HIV in the United States. Following these presentations, we'll also hear from Dafina Ward, the Executive Director of the Southern AIDS Coalition, and Kirk Myers-Hill, founder and president and CEO of Abounding Prosperity, an incredible community-based organization in Dallas, Texas. We need to mount a nationwide response to HIV, but we also know that the Southern United States is an epicenter of the HIV epidemic and has some larger infrastructure challenges and often less healthcare access. Both will provide insights from their work in their communities to understand and respond to the added challenge of COVID-19 on an already big challenge of fighting HIV. Finally, we'll hear from my colleague, Kirk Gresham, who's an associate at the O'Neill Institute. Much of our work is centered on working with the diversity of HIV stakeholders to identify pressing problems and identify actionable policy solutions. Kirk will present his own observations on how we take lessons and information from our presenters and move for collective action. We do not have all the answers. So really, this we hope will stimulate a broader dialogue with our community. And at the end of this, we'll have a question and answer dialogue with our panelists. You can submit questions through the Q&A function. If there's any clarifying questions that we see coming up as we go along, we'll try to address them then, but we'll really reserve most of our time for questions and discussion at the end. Now it's my pleasure to turn things over to Susan Silseth. Welcome.
Thank you, Jeff, and to the rest of the group. I'm pleased to be part of this panel today and able to share the results of our research on the impact of COVID on HIV. As Jeff had mentioned, my name is Susan Silseth, and I'm a consulting actuary with Milliman. We recently published our work, which you can find either by the web link at the bottom of this slide or using the QR code, which I'll provide again at the end of the slide deck. Why don't we go ahead and get started looking at the next slide, please. All right, so today I'll go through the methodology used in our study and talk about the various areas of research that we specifically were focused on. I'll share the results of our work, which included a range of HIV statistics from testing to medication adherence and discontinuations. And then we'll close with some discussion about the impact of Medicaid and expansion of Medicaid coverage in states, as well as talk about some of the limitations of our study and some trends that were produced in the analysis. All right, next slide, please. All right, so Milliman's role in this was really trying to answer the question, how did COVID and the response to COVID affect HIV in the US? So as Jeff mentioned, we already knew that these results probably wouldn't be extremely surprising. There was limited healthcare access during periods of lockdown, especially in the beginning of COVID. One other piece that we did notice throughout the data, both in this study and in other actuarial studies, is that during COVID, the length of prescriptions tended to be extended. So more prescriptions were being filled at a 90-day subscription or prescription versus shorter month-only prescriptions. The other thing that may have happened during COVID is there were potential for limited transmissions. So this was not part of our study, but part of the limitations of what we were able to see in the data that, I think we don't even know the full extent of COVID yet, which is still going on. And we don't know yet the long-term implications of some of the reductions in treatments and diagnoses and so on that happened during the peak of COVID. So as I mentioned, our role here at Milliman was to use the data to investigate these metrics and look at how COVID impacted these over time, especially during the peaks of COVID cases, and then looking at both a national level and more granular at states, regions, and at the MSA level, or metro statistical area. Next slide, please. So this slide is, again, not super surprising, but it's just a recap of the data that we were looking at in our study. So we started out summarizing data from 2019, and then this slide in particular shows the increase in COVID cases from the beginning of 2020 through the end of our study period, which was October of 2021. And so the first shutdowns, if you recall, probably everyone remembers this as a piece of their own personal history now, but was, between February and March of 2020, the first peak of cases happened at the end of 2020 or early 2021, and then the Delta variant happened around October, September of 2021. Of note, this study period does not include the Omicron variant or any subsequent variants, as our study period ended in October of 2021. And actually, Delta did continue for longer than this particular graph shows, but our data ended in 2021, so a little bit, maybe shorter than the true history of COVID. Next slide, please. So in this slide, and actually all subsequent graphs that are going to be similar of setup, we show still in the green line the COVID cases, which you can see the count of cases now on the right vertical axis. And then the rest of the metrics are going to be shown relative to their 2019 values. And so in this particular graph, we're showing that HIV test counts dropped significantly relative to their 2019 average right at the initial portion of COVID. And so where the gray line drops below, it's 60% below where the 2019 average was right at the beginning of COVID. And then as the COVID progressed, you can see test counts did start to increase again, and we're still below the 2019 average, even as of the most recent date of October 21. So if we go to the next slide, you can see a little bit more information. And in this slide, we show the COVID test counts again, same graphic as before, but we're also then layering in the national testing situation as of October. So again, as of a certain point in time, as of the end of our study period, we're showing that many states still have testing levels more than 20% below their 2019 average. So that is the darker red shade in the graph. Those states that have returned to their 2019 average as of October 21 are in the green. So where they're at least meeting or exceeding their 2019 average are in green. And then red are still less than 2019, but maybe not as severe as the darker red. The other key takeaway from this is really in the, as I already mentioned as well, the southern region is going to stand out in some of these graphics as being a little more severe or maybe slower to get to a recovery point. So you can see the bottom, the southern part of the map is going to show more red maybe than other areas that would have a little bit more green. All right, next slide, please. Okay, this is a very similar graph. Sorry, back one. Yes, okay, this one is going to be very similar to the testing because this graph we're looking at diagnoses. Obviously, you can't have a new diagnosis if you hadn't been testing. And so the graph, the line graph looks very similar to the graph in the previous slide. However, maybe it didn't get quite as far from the 2019 average where we had shown the kind of lowest point was 60% below the 2019 average. In this case, it's about 45% below the 2019 average. The other notable item from this is that on a national basis, the diagnoses rates have not returned to the 2019 average during any time during our study period. So again, that the orange line hasn't gone above 0, which is the amount relative to 2019. On the state level side of things, again, you can see 15 states continue to have diagnosis levels at least 20% below their 2019 average. And it's, again, it's pretty similar in the list of states compared to the testing. So again, testing is really the key statistic here. One other piece is that, as I had mentioned previously, given the diagnoses rates are lower, this could be as a result of lockdowns and possibly fewer transmissions. But again, we don't know that's the case. I think we need more time to be able to say with certainty that's what happened there. Next slide, please. Okay, this slide is showing HIV treatment initiation. So in this statistic, we were analyzing patients who started treatment for the very first time. So after they had been diagnosed, then starting treatment. And so again, in this statistic, you can see it bounces around quite a lot, but new patient starts were significantly lower than the 2019 average. And there are, as of October of 2021, this naive treatment starts are still about 17% below the 2019 averages, even as of the most recent time in the study period. So as of the far right side of this timeline. And that's even at a time where diagnoses are approaching the 2019 levels. In terms of states, you can again see sort of that southern region with a bit more red. And there are 11 states that have the naive treatment initiation 20% below or more below their 2019 average amounts. Next slide, please. In this graph, we investigated medication discontinuations. And so how we defined that is we looked at individuals without their HIV medication for at least 60 days after their prescription should have ended. And so we then said if they have no HIV supply for 60 days, that was considered a discontinuation by our logic. There are a few reasons why a patient may discontinue treatment. It could be lack of resources. They could be experiencing side effects. They may have experienced death, or there may be any other reasons for discontinuation. However, we do see that discontinuations continue to be higher than 2019 throughout the study period. And even as of October of 2021, discontinuations remain almost 20% higher than in 2019. In terms of the graph, more states have higher discontinuation than in 2019. There are 17 states now with medication discontinuation rates more than 20% higher than the 2019 average. There are 3 states, you can't tell from this graphic, but in the report itself, it's highlighted there. 3 states where the discontinuation rate is more than 60% higher than the discontinuation in 2019. And those 3 states are Maine, Massachusetts, and Oklahoma. All right, next slide, please. This final statistic is highlighting PrEP utilization, and PrEP is for pre-exposure prophylaxis, which you're probably familiar with, but these are medications individuals can take to prevent the contraction of HIV. Prior to the pandemic, you can see in the upward trend of PrEP use. PrEP use was growing pretty significantly, so about 20% between January of 2019 and March of 2020, or roughly 1.5% monthly. And once the pandemic began in 2020, we saw a decrease in PrEP use month over month of about 1.1% per month. And then after things began opening back up in January, February of 2021, PrEP use started increasing again at a pretty significant rate of about 4% per month through the remainder of our study period. As of October 2021, in this case, the South is actually one of the regions with the highest PrEP utilization compared to its 2019 average, indicating at least this particular statistic has recovered. The only state in the graph that stands out a little bit is my my home state of Wisconsin, which has a lower PrEP utilization compared to their 2019 levels. Next slide, please. So as I mentioned, we also investigated these statistics at an MSA level, so at a larger metropolitan area level. We focused our review of the statistics on areas with a significant number of HIV tests in 2019. And so we sort of wanted to hone in on the recovery or study the recovery of those areas that were most impacted by HIV prior to the pandemic, to see how different areas had responded. And what we saw was, well, that resulted in the study of 37 different MSAs. And generally, these followed very similar patterns to the state level analysis. However, it wasn't always consistent by specific MSAs within the state. A few key notes here were that diagnosis and treatment levels generally still, as it was in the national level, many areas still had diagnosis and treatment below the 2019 average. Rochester, New York was one of the more slow to recover in terms of HIV diagnoses. As of October of 2021, they still had 50% lower diagnosis levels than in 2019. Testing continued to be a concern as of October 2021 as well. And only 7 MSAs had returned to their 2019 testing rates as of October of 2021. So 30 still remained behind. As I mentioned, these kind of 3 key statistics of testing, diagnosis, and naive treatment initiation, those 3 combined, there were 14 MSAs as of October of 2021, with all of those lagging behind the 2019 levels. Next slide, please. Okay, so moving into a few other things that we investigated. We did not look at specific, political stances of these states. However, we did investigate the impact of Medicaid expansion. And this, again, is the expansion of Medicaid coverage to different income levels beyond what the federal levels would dictate. As of October 21, there were 12 states without Medicaid expansion. 11 of them had HIV testing levels lower than 2019, so almost all. And there were 6 of those 12 states had all 3 metrics below their 2019 average. So a pretty large proportion of those states. Thank you. A few limitations, and I'll talk a little bit here about the data that we used. The data we used was from IQVIA, using their medical and RX data. This data includes insured information. So that means that anyone who lost insurance coverage or remained uninsured throughout this study period would look like a person who had no tests or other things like that. So it only incorporated claims data. So if a person had paid cash for their treatments or for their their testing, that would not show up in the data. Anyone who did switch coverage also was difficult to track throughout the data because their identifiers had changed over time, given the data set didn't have other ways to track a particular patient. The other piece was, or another key consideration is that the data didn't allow us to make adjustments based on changes to where people resided. So for example, if a patient left a metro statistical area during COVID, as we know sometimes happened, where certain large cities maybe shrunk in population size during the pandemic or following the pandemic, those patients wouldn't show up as having tests done in that area following the pandemic. Finally, we can conclude as again, not surprisingly, COVID-19 had a significant negative impact on HIV based on the statistics that we studied. This study can really be used to support public health initiatives and really supporting areas in which to focus on some of those outreach efforts. We are investigating an update to this study to incorporate additional data, especially to continue looking at an updated look for recovery as of a more recent date. Next slide. That's it. Thank you so much for including me.
Great. Thank you so much, Susan. That was a very interesting presentation, and I look forward to hearing the questions that you generated when we get to the panel discussion. Now it's our chance to hear from Tristan Mara of GLAAD. Tristan, welcome.
Thank you so much. Thanks, Jeff. And hello, everyone. I'm Tristan Mara. I'm the head of research and reports at GLAAD. It's an honor, honestly, and a privilege to be here to give an overview of GLAAD's newest report. It's called Invisible People, which is a retrospective report on the impacts of COVID-19 and HIV in the United States. So for this report, in addition to an extensive analysis of scientific literature that's been studied to date, we also conducted 26 individual interviews that were moderated by Ipsos. And so really what this did was this allowed us to bring both an academic perspective and a personal voice of impact to this report. The interviews that we conducted explored how the COVID-19 pandemic affected access to HIV-related services, psychosocial services, and other critical support systems. It allowed us to bring a voice to people who really felt invisible. We can go to the next slide, please. So now we'll start to dive into the findings. According to the CDC, racial minority communities in the US are 2 to 3 times more likely to be hospitalized and die due to COVID-19 complications. And this is compared to white non-Hispanic Americans. And there are a number of factors that contribute to this disproportionate impact of COVID-19. They include structural racism that limits access to healthcare, underlying health comorbidities that are significantly associated with hospitalization and death due to COVID, living in high-density neighborhoods and being employed in public-facing occupations where it's just harder to socially distance, and societal inequities such as limited access to COVID testing. We can go to the next slide. We really can't overstate the intersection between HIV and COVID-19, especially as it relates to communities that are the most vulnerable to transmission and death. Both disproportionately impact racial and ethnic minorities, young people, gay and bisexual cisgender men, transgender women, and people who inject drugs. And the same societal level systems of oppression and marginalization that increase vulnerability to HIV are tied to the disproportionate impact of COVID-19. And those include racism, stigma, economic disenfranchisement, and neighborhood disadvantage. We can go to the next slide, please. So continuing into what we detailed in on our report on the effects of COVID and HIV, in 2020, that was the first HIV surveillance report that was put out since the pandemic began. It found a 17% decline in HIV diagnoses. And this is attributed to disruptions in testing and clinical operations that the pandemic caused. And what this means, it likely means that there is a greater unknown number of people that are undiagnosed. In terms of testing, there was a dramatic reduction in testing rates noted during the stay-at-home period, and this is compared to before the stay-at-home period, according to an observational study. HIV home-based self-testing programs were widely implemented and showed high acceptability of these programs. But one challenge of implementing these home-based self-testing kits have been the collection and documentation of the results on the back end. So now looking at prevention, the pandemic did significantly affect access to HIV prevention services. Those include condom distribution, health education, needle exchange services, and the initiation of and continued adherence to PrEP. In the interviews that we conducted, we also found people say multiple times that the surge of public information on COVID-19 overshadowed other important topics like other topics and health issues, including HIV prevention and transmission. And when it comes to care, the pandemic surfaced many new or previously unacknowledged issues that required social or emotional support, and that includes healthcare and wellness needs. Again, through our interviews, many clients that we spoke to reported a heightened need for mental health services and support, and particularly those that were in person. But they said that they lacked the resources, meaning the time, the money, or the knowledge to do so. The overall uncertainty of information about COVID-19 magnified health challenges and caused increased anxiety and depression, which was compounded by those feelings of isolation that we all faced. Honestly, the mental health impact was really something that we heard loud and clear in our interviews. You can go to the next slide, please. And so here are a couple quotes that we have in our report that bring that unique and powerful personal impact, both from the perspective of clients and from community-based organizations. One client that we spoke to mentioned that when in-person support groups halted, they felt like they were missing out on a really critical system that they relied on for guidance, and that virtual groups were just not the same. And a community-based organization we spoke to echoed that sentiment, that clients felt like they were alone during this time because people couldn't participate in those support groups in person. You can go to the next slide, please. And again, this was the power of those interviews that we conducted to bring to life the experiences of those in the community and people most affected. We heard in depth about people's lived experience in this time. When this report was released in October, it was covered first by Time magazine. And this quote on the right-hand side, we think really speaks volumes to how the pandemic disrupted care among people living with HIV. There was a difficulty in getting lab tests done, a feeling of disconnectedness as a result, and the feeling that HIV was an afterthought in the midst of this pandemic. I can go to the next slide. Thank you. Also, through our qualitative interviews, people we spoke to mentioned a few similarities between COVID-19 and HIV, specifically when it comes to the stigma that both carry. And so a few examples of this that people told us about in our interviews. Both are often associated with behavioral decisions, which results in blaming the individual for contracting the illness. There's an element of denial associated with both, that it can't happen to them, which could impact willingness to get tested. Though an important distinction is with COVID, the stigma is more around the unvaccinated from those that we spoke to, or people that refuse to take precautions, which could result in a higher chance of exposure. And there is an unfortunate element of judgment and shame around both COVID and HIV that people talked about in our interviews. You can see that detailed on the quote on the right-hand side. And just a really important note here, every year GLAAD comes out with a State of HIV Stigma report, and this report asks key questions about Americans' attitudes and knowledge of HIV and the stigma that it exists around the virus and people living with HIV. The new report for 2022 is coming out in December, so be on the lookout for that. Advocating for people living with HIV and fighting to end HIV stigma has remained really centered of the core of GLAAD's mission since our founding in 1985. You can go to the next slide, please. So coming out of this research, we've outlined 5 recommendations. Today, I'm going to go over 3 of them. And while these recommendations are coming out of our COVID-19 impact research, they are really applicable and relevant to emerging health crises like the monkeypox virus. So the first recommendation, prioritize the funding of HIV cure and vaccine research while also increasing funding for HIV prevention and education and increasing funding specifically for mental health care services. Second, it's listed as number 4 here. Provide comprehensive public health messages that include both COVID-19 vaccination and PrEP as an important preventative health measure. That surge that we talked about that people mentioned in our interviews, the surge in public health information about COVID-19 can expand to help educate about preventing and treating other viruses, including HIV. And finally, having a clear and simple message is needed really around future vaccine rollouts. And it's important to leverage diversity in message delivery. Seeing doctors and leaders who resemble the full diversity of our community increases that level of comfort. We can go to the last slide, please. So that is an overview of our report. Thank you so much for your time. There's a lot more in this report that you can download and read at the link on the screen. It's glaad.org/COVID and HIV. Also, please feel free to reach out to myself or my colleague, Deshawn Usher, with any questions you have. Thank you.
Great. Thank you so much, Tristan. Again, that's a very interesting presentation. I look forward to having you join the panel discussion. Now we'll turn to Dafina Ward, who's with the Southern AIDS Coalition. Dafina?
Thank you so much, Jeff, and thank you so much to O'Neill Institute for having me today. And I have to say that Susan and Tristan's presentations, I think, set up a perfect picture for what I'm going to share with you today. So my name is Dafina Ward. I serve as Executive Director of the Southern AIDS Coalition, and I'm here to share with you some of the findings from our report on the effect of COVID-19 pandemic, specifically on organizations providing services for those living with HIV and gender and sexual minorities in the Deep South of the United States. And special thanks to the Gilead Compass Initiative and our partners of the coordinating centers of the Gilead Compass Initiative, and a huge shout out to our evaluation partners, Dr. Susan Reeve and the research team at the Duke University Center for Health Policy and Inequalities Research. You've heard already from the first 2 presenters that the South in particular deals with more prevalence among certain populations when it comes to HIV. The Southern US has consistently experienced very complex, multidimensional challenges when it comes to addressing HIV in the region, and COVID has just made that far more complicated. So we know that COVID has exacerbated disparities for those living with HIV, for the communities that are most impacted across the country, and certain populations specifically within the Deep South. The CDC published data in 2021 that revealed the top counties in the country that were identified as HIV, COVID-19 coexisting hotspots. And of those 75 counties in the US, 49 of those are in the Deep South. So 66% of those counties identified as what have been called HIV, COVID coexisting hotspots are in the South. Next slide, please. So I'd like to share a bit about our report, and this will just be a brief summary. I'm bringing you some of the key findings. So between January and June of 2021, we conducted a survey. We received 110 unique responses from CBOs across the Deep South. So it was a survey that was developed and disseminated to organizations and representatives of those organizations providing services to those living with HIV in the South, as well as gender and sexual minorities in the region. And participants were asked a range of questions. We wanted to know about how COVID-19 was affecting their ability to provide services, any disruption, organizational shifts and changes, the impact on their staff, as well as the people that they're serving, and what their needs were that developed during the pandemic. In addition, we also asked questions related to social determinants of health, financial stability, employment, and healthcare access. And so what I'll provide is just a brief overview of some of those findings. Some of the limitations that I think we could address when talking about our method of data collection is that some of the organizations probably most severely impacted by COVID-19 likely did not have capacity to respond to a survey and be engaged in this process. And so we like to name that because we talked to a number of organizations that just did not have capacity to do anything beyond the essential services needed by those that they serve. Next slide, please. So 96% of the organizations that we surveyed acknowledge that there had been either a strong or moderate impact of COVID on their organization. 40% of the organizations indicated that all their services were still available during the pandemic, and 42% indicated that while all services were available, that they were doing that at a reduced capacity. And the remaining 18% of organizations indicated that only select services could be provided during COVID-19. Next slide, please. So there were layers. When we had these conversations or did these surveys and follow-up conversations with organizations, there were layers of impact. And so this question spoke specifically to the impact of COVID-19 and their staff. And so what we recognized most significantly was the impact on the volunteer workforce. The fact that CBOs rely heavily on volunteers to be engaged in a range of capacities in their service delivery, and that COVID really made that non-existent for a number of organizations. Also, each organization that's responded to the survey did report that they received some form of a COVID relief grant, be that PPE funding or some other type of resource. And while a majority of organizations did not state that they intended to have to do layoffs or furlough, they did speak to the anxiety and fear of their staff as related to that being an occurrence due to the pandemic. Next slide. So many organizations talked about the fact that where they needed most resources, and I appreciated Susan's takeaway around more resources, specifically those that are unrestricted for them to meet their needs. I'm sorry, that was Tristan and GLAAD. So yeah, so 52% of them acknowledged that they needed more resources to assist in their overhead. A lot of organizations were challenged around paying their basic rent and utilities during the pandemic because they were not able to generate revenue as they usually would. A number of them asked needed financial assistance, not just for the providing of overhead, but also just for service provision. So over half needing financial assistance just to provide services. Half of them reported needing technology related support. And some of that was around equipment. Some of that was around their own staff's capacity to navigate providing telehealth services and other technology-based services, and even how to do outreach and engage their clients utilizing those virtual services and virtual methods of engagement. While nearly half reported that they needed support in even transitioning, like how do we even go from in-person support groups, which were discussed earlier, to getting folks to be comfortable in coming into a Zoom room for this level of confidential and very intimate conversation. Also naming the fact that so many of their clients were living in homes and spaces where due to stigma or other causes, people that they live with and cohabitate with may not know their HIV status, that they did not want to share intimate details around their lives, where they may be in a shared space versus being in an in-person, enclosed and safe and brave support space. And about 12% said they needed guidance in reopening. While the majority of them reported that they were following CDC guidance, there was still some hesitation around how to best reopen and to fully provide services in a way that was going to be most effective and safe for their staff and for those they serve. Next slide, please. So it was, as was mentioned, a number of organizations expressed that there was difficulty switching to virtual programs for a number of reasons. And as a result of staff capacity or not having the appropriate equipment, and in many communities, unfortunately, even the internet and bandwidth to effectively provide those services, there was also how do we even communicate this adjustment? Because there was the assumption in many communities that the organization was just shut down, because everything is shut down, including my service provider. So how do we best communicate when we don't have an effective means of reaching a client, say by phone, where we don't know if this address is still going to be the right address? How do we engage clients to let them know that we are still a resource and still here? Next slide, please. So as we know, when we talk about the Southern United States, one of the greatest barriers that's constantly lifted up is the fact that there is not consistent, reliable, accessible transportation in many of our communities. And I think this particular data point is interesting, as it reveals that more than 25% of clients, when you're looking at this 35% window, that more than 25%, but less than 75% of their clients do not live within the county where the organization is located. And what that translates to in looking at that is the fact that many people would have to travel and be able to get back and forth to the service provision. And so there was this, it was exacerbated when we're talking about service deserts in southern communities. The transportation barriers that existed made it even harder to provide what might be drive-up services or any type of in-person engagement, where folks are often relying on a shared ride with someone where that might not be available, and just a number of challenges that people found. And so that research has shown us that counties with the greatest number of individuals diagnosed with HIV, even before COVID, and the most suboptimal geographic access to care are predominantly in the South. So we know that this was a substantial issue, particularly in Southern communities. Next slide, please. My last slide. So this points to the needs that clients were reporting to organizations in the South. And as you see, there were significant needs reported at high rates, but we like to point to specifically 82% of these organizations reported clients' requests for support around food and mental health services. And food and mental health services were coming in at the same rate of need. So this definitely speaks to where we may continue to sit in the need for mental health service provision as a result of COVID and a number of other issues facing clients served by these organizations. And lastly, thank you so much. So the report can be accessed here with this code, and it can also be accessed on the Southern AIDS Coalition website. And as what we take away from this, as we think in 2022 and beyond, we know that there's a great deal of fear and anxiety around what the end of the public health emergencies will mean for those that are most impacted by HIV in our communities, and particularly in Southern states where folks could be disenrolled from Medicaid as a result of a public health emergency termination. While we currently still sit through an extension at the moment, there has to be work done to make sure that we preserve the systems that have been built as a result of COVID, to make sure that the CBOs that are serving those most impacted and the communities most impacted don't continue to lose ground. And thank you so much. My contact information is here, and we would be happy to share more with you and about our findings. Thank you.
Great. Thank you so much, Dafina. Once again, a great presentation. Now we'll hear from Kirk Myers-Hill of Abounding Prosperity. Kirk, thanks for joining us.
Thank you guys for having me. So I didn't have any slides to present, but I wanted to add, I guess, the last piece so we can just talk about some of the things that we've seen that reiterate what has already been presented thus far. But from a local perspective in the local jurisdiction of Dallas, Texas. So I want to start with 3 points. I'm going to cover 3 points: overall atmosphere, service delivery impact, and successes. The overall atmosphere, fear, concern, sadness, grief, and anger, and uncertainty were the backdrop of what we had to use to address how we were going to provide services during the pandemic. As a consistently trustworthy and reliable CEO within our communities, AP Inc. was heavily relied upon to provide accurate information and the basic essential services needed to address their valid and transitioning emotions. Our mostly uninsured and underinsured clients needed assistance navigating, accessing healthcare services, just basic information, all of those sort of things. We had to start with that as a backdrop. In the midst of economic shutdown, gig workers, which comprised a lot of the people that we serve, were now faced with no opportunities for employment. When we talk about marginalized communities, trans sex workers, trans performers, bartenders, all those sort of folks that work gig jobs, that was the overall atmosphere in which we provided services. Service delivery impact from March 1st, 2020 through May 31st, 2021. Let me back up before I do that. We also were deemed essential workers by our county health department, which was a lot different than other jurisdictions, because a lot of the drops in numbers and things that other jurisdictions saw, we didn't have that luxury because we never closed. So from day one, we were providing services. And so we were deemed essential health workers by our local and state health department, by the way. Health department referred folks to us while they used all of their resources to vaccinate. Then the county health department, which consisted of its HIV and STI clinic, mostly STI treatment, were referred to our clinic. So they deemed us essential workers and then made referrals to our clinic. But from March 1st, 2020 through May 31st, 2021, AP Inc. saw a 76.7 increase in HIV testing when compared to the previous year, 178.5 increase in GC tests, 227.5 increase in syphilis testing, 137.4 increase in Hep C testing. From March 1st, 2020 through May 31st, 2021, we saw 1,164 patients for our clinic and STI treatment, PrEP and NPEP services, and HIV care. For 28 weeks during the pandemic, 16,788 households were provided fresh food, inclusive of produce, dairy, and protein. Distributed almost $30,000 in Visa gift cards to offset the cost of household essentials, i.e. gas, food, etc. Populations prioritized Black, Latinx, MSM, Black cis women, trans people of color, formerly incarcerated, sex workers, DJs, club staff, drag performers, bartenders, and exotic dancers. We distributed close to 250 COVID-19 prevention and care kits that contain PPE, sanitizing products, thermometers, herbal tea, etc. From August 14th through December 30th, 2020, we provided 107 households with short-term rental assistance and utility assistance for a total of $1.5 million. 91% identified as Black, African-American, and or Hispanic, 80% at or below the 50% area median family income, 55% identified along the LGBTQ spectrum, 50% were female-led households. September 9th through December 31st, 2020, 325 individuals affected by COVID received mental health services through our organization. Next, I want to talk about successes. AP Inc. did not see any decreases in service renderings due to being labeled the essential workers and remained open throughout the pandemic, which I've already addressed. Telehealth and telemedicine were already in place prior to the pandemic, so amping up the utilization of these services aided in decreasing service interruption. In addition to, we were able to start PrEP and care services, but during the pandemic, we were able to, on a case-by-case basis, send out a team on the mobile unit if we had care clients that needed blood draws to for their labs. So that was something that was highly utilized as well. We also have integrated pharmacy services, so there was no interruption in delivery of meds because we already had couriers that would do that. Expansion of service provision, financial support services for rental and utilities, mental health expansion, vaccine equity programs were created, fresh food pantry, expansion of priority populations. We saw an increase in individuals that identified as heterosexual accessing services.
I'm sorry, Kirk, are you finished now?
Perfect. I thought that would give more time for a conversation.
No, I appreciate that, and thanks for this remark. Now we'll turn to Kirk Gresham, my associate at the O'Neill Institute. Kirk?
Good afternoon. I want to start by thanking all of the presenters, and I'll start with Susan and Tristan for presenting their respective reports with new data documenting the impact of COVID on HIV prevention and treatment, as well as on the quality of life of people with HIV. I also would like to thank Dafina and Kirk for providing context regarding COVID's impact on the Southern United States. Over the past year and a half, the Infectious Diseases Initiative at the O'Neill Institute has brought together diverse groups of stakeholders to assess COVID's impact on and how our policy responses can address both COVID and HIV. We've released several briefs informed by meetings with community-based organizations, medical providers, local and state health departments, and researchers. Over the next few minutes, I will highlight some of the key takeaways in relation to what we heard today. Next slide. People with HIV and those in need of prevention services rely extensively on functioning health systems and a range of social services, including housing and nutrition assistance. Yet the pandemic caused many clinics and community-based organizations to temporarily close and shift to telehealth if they had the resources, while some never reopened. Extensive resources were allocated to mount an emergency response to COVID, which included the detailing of many HIV providers, infectious disease experts, and community health workers. While critical, this impacted the ongoing HIV response. The disproportionate impact of COVID on communities already burdened by HIV has further challenged our efforts to meet goals to end the HIV epidemic in the United States. Next slide. The COVID pandemic has been extremely traumatic for everyone. However, it disproportionately affects communities impacted by HIV. Trauma is a significant contributor to outcomes as well as quality of life. People who provide healthcare and other services to impacted communities also experience exceptionally high levels of stressors. The trauma of COVID is deeply intertwined with COVID and other syndemic factors, including mental health, substance use disorder, homelessness, and other infectious diseases, including STIs. The recent outbreak this year of monkeypox is another example. Living with HIV during COVID for many people, as some of our presenters have shared, also means living with multiple health and socioeconomic challenges. Next slide. Despite 4 decades of major advances in HIV, including a large and growing array of effective treatments and prevention modalities, many people with HIV live in poverty and are burdened with varying sources of stigma and trauma and an array of complex health and social challenges. Stigma and discrimination negatively impact quality of life for people with HIV and also fuel large disparities in HIV treatment and prevention. States and jurisdictions with laws that criminalize HIV and restrict access to reproductive health services, for example, report worse HIV outcomes and higher levels of stigma among communities impacted by HIV. These communities are also discriminated against, limiting their housing and employment opportunities. Our country's main way of providing income support is through the Social Security disability programs. An estimated half of adults in the US with HIV receive federal disability benefits, but payments for these programs, however, have left people near or below the federal poverty level. Quality of life issues for people with HIV are a pressing concern, and while there may be interventions and adaptations to services to better meet people where they are in treatment and prevention, addressing them at large will require systems level changes. Despite the needs for these changes, next slide, the federal policy response to COVID provided critical stopgaps for healthcare access and coverage and housing. Maintaining Medicaid coverage among people living with HIV not only keeps them with access to care, but also prevents the cost shifts onto Ryan White AIDS program. Vaccination, the availability of rapid tests, and antiviral treatments aim to mitigate COVID among populations impacted by HIV. Still, large disparities have been observed among racial and ethnic minority communities, including lower vaccination rates and higher case rates, hospitalizations, and deaths. The disappearance of these initiatives will be deeply felt and may exacerbate inequities. Next slide. While it is clear that COVID has indeed derailed our efforts to end the epidemic, our policy responses, particularly those implemented as part of the emergency response, as Dafina and others mentioned, are critical to responding to HIV. Moving forward, a sustained commitment to HIV also requires us to develop and implement a syndemic response that responds to COVID, STIs, mental health, and substance use disorder. This sustained commitment to HIV will also require us to continue adapting our prevention and treatment service delivery models to withstand future public health emergencies to maintain engagement in treatment and prevention services for populations impacted by HIV. I really want to return back and thank Susan and the Milliman team for presenting this data, because we've known that COVID-19 will have an impact on various kind of indicators within the prevention and treatment continuum. And I think one of the most important things moving forward is being able to kind of understand and respond to those disruptions. I thank you for your time, and I look forward to the discussion.
Great. So thanks to you, Kirk, and everyone. So now I would like to encourage all the panelists to to engage in discussion. Before we get into any specific questions, do any of you have any clarifying comments or things you want to ask other presenters? Were you surprised by something? Or you want to react to anything you heard?
I'd love to ask a quick question of Kirk, because that was my first time hearing about that essential health worker designation for you all during COVID. I would love to know how that impacted staff morale or any other impact that may have had on your staff and their longevity and their own health and wellness during the pandemic. And thank you for everything you do.
Thank you. And I think that's a good question. But because because we're a peer-based program, then I think the staff was, excited to be a part. And I think we had an opportunity to step up in ways that Black people, quite frankly, and brown people hadn't had an opportunity to do, certainly not with HIV. And so I think this was an opportunity for the rally and community mobilization activities were at the forefront. So we did not have any resistance internally or externally with what we felt like we needed to do for our own community.
Yeah, if I could just make an observation, I've said this before, like I love our communities. And one thing about our community, we're not in this for the money. We do it because we care about our community. So with all the challenges that we always face and then the added burden of COVID, let's just acknowledge, I just think back to in those first weeks of the pandemic when everything shut down, people just scrambled, but they kept services open. I think about how scared we all were. We were wiping down boxes of groceries and things, but yet harm reduction workers out in the field cared so much, they just kept working at their own risk. And so we should just acknowledge the things that the commitments that people have shown. I'm wondering though, if any of you have any observations coming out of this, how do we take that energy and refocus on filling the gaps along the HIV care continuum? So we know that COVID has impacted us, maybe set us back a little, but how do we regain some of our momentum to really fighting HIV? Are there any lessons set from what you've seen with COVID that we can apply to our HIV efforts?
Sure, Jeff. I want to thank you for what you just said, and certainly, thank all of us for our efforts, because it is taking for the efforts. Even with this presentation today, this is necessary work. Now, one of the things that we have found is with COVID, and I just want to throw monkeypox in the room too, because obviously they're all existing together, is that people now are more interested for sure in integrated services and the one-stop shop. And what we have found is that people that wouldn't ordinarily test for HIV would come in for a monkeypox vaccine or COVID, and then we offer it in addition to. So then I think that has served to remove some of the barriers and maybe even some of the stigmas from all of the 3 health areas that we have talked about. And so now to be able to talk to people from a perspective of overall health and wellness.
Thank you, Kirk. I see nodding heads. Anybody else want to jump in on that? So let me just jump in as the questions start to come in. I mean, Tristan, I heard one thing from you, and that was the emphasis on the need for mental health services. And I'm just wondering, that could mean lots of things, or there's ways we could address this. Do you have thoughts, or others have thoughts on how we do this? Probably before COVID, we knew that, this is one area where we've underfunded services. But, I think providers need services, community members, but they need different kinds. Can you reflect on what you think would be really most important to address this particular gap here?
Yeah, I mean, definitely. We heard through our research that mental health services and support services just weren't the same virtually, but there really was a need for that connection. And you're right, Jeff. We heard that from community-based organizations as well. Obviously, their needs were different from people in the community, but everyone really expressed just a need for connection. And part of what we heard in our interviews was that if clients had established healthcare providers at the beginning of the pandemic and they weren't shifting providers, that the disruption and the level of care and support felt better than people who had to shift healthcare providers during the pandemic. So that that is one thing. But yeah, I mean, it's very important to maintain those connections, and even community-based organizations that had to close for a small amount of time, they were really able to innovate and advocate for their clients. And so the level of care was really as minimal of a disruption as it could have been. And I'd just like to toss it to Deshawn in case he had anything else to add there on support systems.
Yeah, I think one of the things that COVID definitely showed us was the innovation around funding, particularly. So when we talk about social determinants of health, as to like we were actually able to like really apply those fundings across the board, right? So to get people to services, to get people connected to care, to prioritize mental health, as that was a way for people to also like engage with medical providers. I do think that it also enabled us to look at like the innovation of telehealth, and what like classified as like who could administer it and who could get reimbursed for some of those things. And so I think those were some of the things that had came up inside of like the research that we were hearing, and speaking with community-based organizations, that a lot of it was centered around being able to actually apply the funding that has traditionally only gone to testing and treating and preventing HIV, in the sense of like all biomedical or all testing based, but like again looking at the person holistically to enable and ensure that like we could provide mental health services and other services.
Great, thank you. Kurt Gresham, did you want to jump in on this question about mental health? Or you're muted, sorry.
Sorry. No, I mean, I appreciate this conversation, and I hope we can return back to it. I was just responding to a question in the chat about looking at kind of the wraparound services and the other kind of programs that Kirk Myers was mentioning. And the question in the chat was, did these sort of services have a mitigating effect on people dropping out, falling out of care? And I think that's a really interesting question. I don't know if we have we can't necessarily answer that now. I mean, I think maybe based on the kind of experience from Kirk might be able to respond to that. But thinking further kind of research questions and like the future and the impact of the Milliman report, and really thinking through the various levels, various kind of steps of continuum and engagement and care, and where possibly there might be geographic differences and where these effects might have been mitigated. So I'm curious to hear about that.
Great, thank you. Susan, can we maybe turn to you? You said a couple things about PrEP that caught my notice. One, you mentioned 3 states had PrEP discontinuations that were more than 60% higher than 2019. I think you said Maine, Massachusetts, and Oklahoma. I don't think those states typically look alike in a lot of ways. Do you have a sense of was there anything that united them? But you also said, I think that PrEP use compared to 2019 was higher in the Southern US. And that also surprised me. Do you have any more to add or any observations you can make about either of those points?
Sure, thanks. The first one was actually all medication discontinuations in those particular states. So that was more focused actually on treatment discontinuation versus PrEP. So that's probably the disconnect between those particular statistics that you're talking about.
Great, thank you.
Yeah.
And then this higher PrEP use in the Southern US, anything to explain that, or our friends in the South, do you have any thoughts on that? Does that surprise you?
Yes, it surprises me.
Okay.
I mean, I'm happy to hear that and look forward to looking at the report more closely, but definitely based on what we've heard in many of our communities, it's surprising to hear that may be the case. But then I look at Kirk Myers Hill and the work in Abounding Prosperity, and then you have certain spaces where there seemed like there were elevation or increase in service delivery, where that may explain where some of that is happening in certain pockets in the South. But I definitely would be surprised to think that would be outside of maybe more metropolitan or higher service areas.
Right. Kirk, did you have anything to add to that?
Well, I would say it's consistent with what I've just presented. So, but again, I know that we're an exceptional case in the sense that we didn't closed, I mean, day one. So, and, again, we also mentioned our mobile testing unit, which has an ability to prep. So not only is it is in the community, but again, I think that may have certainly helped with our uptake. But the other thing too is that we can do what we call teleprep, which is a home prep testing kit, prep kit for at home use. So I think all those things have certainly helped in our jurisdiction.
Great. So one thing, our work over the past year, we did some work on trauma. We talked to people with HIV. We talked to healthcare providers, health departments, community-based organization staff, and everybody's traumatized. But as I was also reflecting, people stepped up, and I think it's great. But then once people respond to a crisis, they sort of like come down, they exhale, and maybe they'd I don't know, fall apart, or they need a break. But then we've had monkeypox, and they haven't had a break. Do you have any ideas on how we can support our workforce, bolster people? Because we've got to keep going, right? We can't fall apart. We can't move on to other things. How can we support our workforce? So any thoughts here?
I think it's key to first acknowledge that is even the case for the folks who are on the ground doing the work, and that we remove this expectation that we're not human in doing this work, and that people are dealing with their own challenges and hardships. And for a lot of the organizations that we've talked to, that's been tremendously helpful. We've talked about mental health. We cannot overlook the mental health needs of the people who are doing the work. And as much as we can support that. And, I think it's also important to think about, how do we ensure funders were so generous during COVID with loosening restrictions around funding and making funding unrestricted and trusting community and organizations to do what they needed to do. And I think that's one thing we need to insist carries forward, and that there continues to be resources available so that organizations can support the needs of their staff and their teams who are doing this work. And how do we make even coming into this field of work more appealing? Because it's about maintaining and sustaining this workforce too, because we already know about the challenges around recruitment and sustaining folks in this work as in so many other fields. And so those are some of the key things that I think are critical for us to make sure that we're taking care of our workforce.
Great. So I think we're about coming to the end of our time. I just want to give all of our presenters a chance. Well, I'm sorry, I see Deshawn had your hand up. But maybe I could just give everybody a chance to give any closing remarks or last remarks, but we'll start with you, Deshawn. So maybe you can make your point and then give us any other reflections you have.
Yeah, I was just going to say that I think it's important to note that COVID had impacted so many different industries and workforces. And so, of course, HIV prevention, healthcare was one of them, of course, but then also thinking about how many folks from the HIV prevention field sort of kind of left to go to COVID research and prevention and tracking and stuff like that too. I think that will be an impact that we'll feel as things continue to ramp up and open. But then also one of the things inside of the GLAAD Invisible People report is that if you look at the map of COVID and HIV and monkeypox, it literally is the same map of where the burden exists and where that stress is existing, particularly on the workforce. And it's largely in the South and largely within metropolitan areas. And so it is thinking that I think there has to be a reframing around what health equity looks like, and how do we ensure that we're not enabling the workforce, but also those local communities so that they do have the resources whenever any communicable disease happen, so that they're best prepared to fight against it.
Great, thank you. Tristan, did you want to add anything to that or any closing reflections?
I don't have anything else to add. I think Deshawn said that really wonderfully. I would just again like to thank everyone on the panel today, and also everyone who joined us. It was an honor to talk about this very important work and also talk about different solutions or ways that we can continue to move forward to really find ways to continue to fight against HIV in the midst of pandemic. So thank you all.
Great, thank you. Now, Susan, one of the things I appreciate is you in some ways brought the receipts for things that we've all been saying. You've given us the proof of things we've observed, but I'm just wondering, do you have any closing thoughts or anything you want to leave us with?
Yeah, I would just also like to thank the rest of the panelists for really bringing kind of the human element to this conversation. And as we talked about, my analysis and study really focused on what the data was saying, but I really thought it was great to hear more of what, qualitatively, what else was happening that went along with these data and statistics. So thank you for allowing me to present this information and and sharing your perspectives too.
Thank you. So Kirk Myers-Hale, one of the things I appreciate about you is like we all get, as sometimes as advocates, we frame challenges. You also talked about successes, and I appreciate that. Is there anything else you want to leave us with?
No, just as I was thinking, well, yes and no. What I wanted to just reiterate is that certainly in the backdrop of HIV prevention, and a lot of us have been doing this work, we don't have to always think about recreating the wheel. We already have some great systems in place, and how do we continue to build on those versus recreating a new system when not needed. So when needed, we create them, but when not needed, resting on some of those established networks and delivery systems that are already out here that are working.
Great, thank you so much. Now, Dafina, you always bring passion to this and appreciate, and highlighting just the need of all your community-based organization members that do so much important work. Do you have anything else you want to say to us?
Yeah, well, yeah, like everyone else, I want to echo my appreciation for being able to share this space with all of you and for everyone who's participating on the webinar today. I think I would just like to remind us to be diligent. Look, I can't even talk. I'm tired. So we have to be diligent in this work, right? So continuing to recognize where the opportunities are for advocacy around continuing to address what's happened as a result of COVID and what is happening. And so recognizing there's a long way to go before we'll know the true impact of COVID on our work in HIV. And so being diligent when we see the income of the public health emergency, how do we hold federal and state partners accountable to make sure the communities continue to get what they need and that they don't see a reduction or cut in these very essential services. So I would just remind us to be diligent, although it's not in front of us every day like it may have been before, that there's still so much work to do and so many lessons to be learned that I hope that we capture and that we have resources in place to capture what our organizations have done and what can be carried forward for issues to come.
Great, thank you so much. Now, Mr. Grisham, what are your final words for us?
Well, first I want to say I'm pretty sure Dafina was mixing diligent and vigilant. And I think we have to be both. So I appreciate that. I just want to leave the one little kind of like statistic I want to leave everyone with is that recognizing where we've come with HIV, particularly over the past 12 years, our viral suppression rates from 2010 to 2019 have increased a lot. We're up to, for patients engaged and receiving at least one form of Ryan White service, it's up to almost 90%. So I think we do have a model for effective response and prevention or treatment for infectious diseases with HIV and Ryan White. I think what Susan and the Milliman team bring to us is complicating that and thinking about kind of our diverse payer system and how these challenges are and kind of these successes we've seen in HIV kind of don't always appreciate kind of the disparities that we see across the country. And so I think I agree. I think we need to be vigilant, diligent in kind of making sure that this work and this report, that these receipts that Milliman brought to us inform our future research and policy agenda.
Great. Thank you so much. So I just want to thank all of you. This has been a great conversation and a really important one. To those, a couple of people in the chat raised the question of would the slides be available? And I think the authors of these reports encourage you to actually read the full report. And so that's why we posted it in the chat. And you can also, looks like we just posted the YouTube channel. We will be posting the recording of this webinar for you to review or to share with others if you want to just watch this again. But I just want to thank all of you for joining us for this conversation. Hopefully it's just the beginning or a continuation of ongoing dialogue our community needs to have. But I want to just thank all of you for the work you do every day. Our communities deserve the work we do to end the HIV epidemic, and thanks for being a part of it. Have a good day.